Is on that? Yeah, it's not coming there.
Good morning, everybody. The next topic is recent recommendations on antiplatelet, anticoagulant therapies during regional anesthesia, talked by Dr. Jitendra. It is my pleasure to introduce Dr. Jitendra, Senior Consultant and Head of the Department, Anesthesia and Critical Care Medicine, Aster MedCity, Cochin, Course Director for PDCC in Neuroanesthesia and Neurocritical Care. Areas of interest, neuroanesthesia and neurointensive care, regional and pediatric anesthesia and postoperative critical care management. Has authored for a chapter in textbook of neurosurgery, anesthesia for awake craniotomies, and has few journal publications, faculty at various state level and national level conferences. Thank you.
Thank you, sir. Good morning, everyone. Topic which doesn't finish in 15-20 minutes, but I'll try to reduce that slides and let me thank the organizers for giving me this opportunity here to present this topic. Now, evolving standards for prevention of perioperative venous thromboembolism and increasingly potent antithrombotic medications have actually resulted in concerns regarding the heightened risk of neuraxial bleeding. There have been multiple guidelines, recommendations all written to address the perioperative management of antiplatelets and anticoagulants. Furthermore, the societies and organizations seeking to address these concerns through guidelines in perioperative management have issued conflicting recommendations. So in response to these, actually the American Society of Regeneration and Pain Medicine in conjunction with European Society of Anesthesiology convened its 4th Consensus Conference of Regional Anesthesia and Anticoagulation. This was way back in 2018. And based on limited clinical data and animal data, these guidelines do not define standard of care. They are not intended to replace clinical judgment as applied to a specific patient scenario. So that comes to be the prime importance. You need to look at your patient scenario as well as your clinical practice. Now, many of the patients actually will be older patients. They may be on antiepileptics and antiplatelets and anticoagulants, and they may require surgeries or invasive procedures. And younger patients, they come as an emergency with all these antiplatelet drugs, and you may have problem in actually judging whether to go ahead with regional or general anesthesia. In addition, anticoagulant use is increasing due to availability of newer direct acting oral anticoagulants, which are easier to handle for the patient than the vitamin K antagonist. So it's estimated that the patients with AF, which is a dominant clinical indications for long-term anticoagulant therapy, almost 10 to 15% will require treatment interruption annually for elective surgery or invasive procedure. So this is one of the articles which has come up in Regional Anesthesia and Pain Medicine. This is in 2000. This was 2018. The ASRA guidelines. That's the 4th edition. And we'll be following few of these, and there are some recommendations, some changes. They have actually taken a systematic and general review of relevant literature between 2010 and 2017, and they formulated these guidelines. This is another article which has come up recently in the European Journal of Anesthesiology in 2022, where the regional anesthesia patients on antithrombotic drugs, which was a joint ESA and ESRA guidelines. So we'll come to it towards the end of the talk. Now let's look at the subcutaneous unfractionated heparin. So low-dose subcutaneous unfractionated heparin is commonly used for prophylaxis against development of venous thromboembolism, general and neurological cases surgeries. Administration of 5,000 units of heparin subcutaneously twice daily or thrice daily has been used extensively and effectively for prophylaxis against DPT. There is often no detectable change in clotting parameters as measured by APTT or antifactor X level or heparin level. However, there is a minority group of patients, perhaps up to 15%, who may develop measurable changes in coagulation, although APTT rarely exceeds 1.5 times the normal levels and normalizes within 4 to 6 hours. So there was some statements in 2010 by the ASRA guidelines where they had mentioned actually in patients receiving prophylaxis with subcutaneous unfractionated heparin with the dosing of 5,000 units twice daily, there is no contraindication to use of neuraxial techniques, and the risk for neuraxial bleeding may be reduced by delay of the heparin injection after the block, and may be increased in debilitated patients after prolonged therapy. So in patients receiving doses greater than 10,000 units of unfractionated heparin daily, or more than twice daily dosing, suggestion was that neuraxial block be avoided. Later, the new guidelines actually allow 5,000 units thrice daily, but also suggest that the timing of the needle placement and catheter removal, regardless of twice daily or thrice daily dosing, coincide with lower levels of anticoagulant activity. These recommendations are actually based on pharmacology of subcutaneous 5,000 units dose of unfractionated heparin, which results in an anticoagulant effect of 1 hour after administration that persists for 4 to 6 hours, and hence 4 to 6 hour delay after administration for needle placement. There's the guidelines. Finally, these recommendations are consistent with those of European Society of Anesthesiologists, as well as the British and German guidelines, which permit an international set of guidelines. Now, when you look at the preoperative low dose and preoperative high dose unfractionated heparin, and also of the therapeutic dosing, this you need to know about the timings in this. This come up in the ASRA guidelines. In patients receiving subcutaneous low dose unfractionated heparin with a dosing of 5,000 units twice daily or thrice daily, you can conduct a neuroaxial block 4 to 6 hours after the heparin administration of the coagulation status has been checked. This is a grade 2 recommendation. And if you're using a higher dose of unfractionated heparin for thromboprophylaxis, that is example like individual heparin dose of 7,500 to 10,000 units twice daily, or a daily dose of less than or equal to 20,000, then again neuroaxial block can be done 12 hours after subcutaneous heparin administration and assessment of coagulation status, again grade 2C recommendation. And if you're using unfractionated heparin for therapeutic dosing, that is more than 10,000 units subcutaneous per dose or more than 20,000 units total daily dose, then you have to wait for 24 hours after heparin subcutaneous administration and assessment of coagulation status. And when you go to the postoperative dosing of the low dose unfractionated heparin, there is no contraindication to actually maintaining neuraxial catheters in presence of low dose unfractionated heparin. Catheter removal, however, should occur 4 to 6 hours after the heparin administration, and subsequent heparin administration may occur 1 hour after catheter removal. Now, postoperative higher dose of unfractionated heparin, again the safety of indwelling neuraxial catheters in patients receiving doses greater than 5,000 units or greater than 15,000 units of unfractionated heparin daily has not been established. Now, suggestion is by the ASRA is that risk and benefits be assessed on an individual basis, and that techniques to facilitate detection of new or progressive neurological deficits, that is enhanced neurological monitoring may occur, and neuroaxial solutions to minimize sensory and motor block. And these risk and benefit ratios may be applied. This is a grade 2 recommendation, 2C recommendation. Now, low molecular weight heparin is being routinely used for many of these patients as prophylaxis for DVT in the preoperative period, and we need to know it acts through the anti-factor 10A effect, and at peak levels are around 3 to 5 hours, and elimination half-life is 3 to 6 hours after subcutaneous injection. So you need to know about the half-life of each of these drugs, based on which you have to decide upon your regional anesthesia technique. And prolonged low molecular weight heparin therapy may be associated with accumulation of anti-factor 10A activity and fibrinolysis also. I'll just skip these slides. Now, preoperative low molecular weight heparin. So, recommendation is actually needle placement should occur at least 12 hours after a prophylactic low molecular weight dose heparin. That's a grade 1C recommendation. And in patients administered a low dose of low molecular weight heparin 2 hours preoperative, usually in general surgery patients, recommendation is against neuraxial techniques because needle placement will occur close to the peak anticoagulant effect. Again, grade 1A recommendation. In patients receiving higher therapeutic dose of low molecular weight heparin, such as phenoxyparin 1 mg per kg every 12 hours, or enoxaparin 1.5 mg daily, or dalteparin 120 units per kg every 12 hours, or 200 units daily, the ASRA recommends delay of at least 24 hours prior to needle or catheter placement. That's again grade 1C recommendation. Now, if you go for twice daily prophylactic dosing, this dosage regimen is associated with increased risk of spinal hematoma. And recommendation is the first dose of low molecular weight heparin should be administered, this is the postoperative period, should be administered the following day or no earlier than 12 hours after needle or catheter placement, regardless of anesthetic technique, and only in the presence of adequate surgical hemostasis. Now, indwelling catheters should be removed prior to initiation of low molecular weight heparin thromboprophylaxis, and administration of low molecular weight heparin should be delayed for 4 hours after catheter removal. There again, grade 1C recommendation. Now, previously recommended was a first dose 24 hours after needle or catheter placement, and a delay in low molecular weight heparin dosing only 2 hours after catheter removal is being changed to 4 hours. And these recommendations incorporate labeling changes made by the FDA. So these are guideline changes in ASRA. Now, if you look at the single daily prophylactic dose in the postoperative period, recommendation is the first postoperative low molecular weight heparin should be administered at least 12 hours after needle or catheter placement. And the second postoperative dose should occur no sooner than 24 hours after the first dose. And indwelling neuraxial catheters do not represent increased risk and may be maintained. However, and no additional hemostasis altering medication should be administered because of additive effects. And the catheter should be removed 12 hours after the last dose of low molecular weight heparin. And subsequent low molecular weight heparin dosing should occur at least 4 hours after the catheter removal. Now, previously recommended was 10 to 12 hour range for both needle or catheter placement and catheter removal, and subsequent low molecular weight heparin was previously 2 hours after catheter removal. That's again changed to 4 hours. Now, fondaparin is another drug which has got an anti-factor 10A effect, and it's actually got a prolonged half-life of almost 21 hours, and allowing for a single daily dosing, with the first dose administered 6 hours post-operatively. And based on sustained irreversible antithrombotic effect, early postoperative dosing, and the spinal hematoma reported during initial clinical trials, it is recommended that until further clinical experience is available, performance of neuraxial technique should occur under conditions used in clinical trials, whereas they use a single needle pass, a traumatic needle placement, avoidance of indwelling neuraxial catheters. If these are not feasible, an alternate method of prophylaxis should be considered. That's a grade 1C recommendation again. Neuraxial catheters to be removed 6 hours prior to the first postoperative dosing. Now, there are new or direct oral anticoagulant, anti-factor 10A agents, that's DOAC, that's routinely used ones are rivaroxaban, apixaban, edoxaban, and betravaxin. Used again for primary prevention of VTE after elective total hip replacement surgery, prevention of stroke, etc. And these drugs are at least as effective anticoagulants as a vitamin K antagonist, and they have actually replaced the vitamin K antagonist because it's found to be safer in terms of bleeding, have a rapid onset of action, and a short half-life, and are devoid of need for routine laboratory testing. So until recently, any specific antidotes were lacking, but there are a few antidotes for some of these drugs which have come up in the market, still under trials. So when you look at rivaroxaban, the brand what you get is Xarelto. If a neuraxial block is considered in patients treated with prophylactic rivaroxaban when the dosing is less than 10 milligram per day, a time interval of 22 to 26 hours should be observed between the last dose of rivaroxaban and the subsequent neuraxial puncture and catheter manipulation or withdrawal. Now, you can the newer recommendation is like this was the early guidelines in 2010. Between 2010 and 2017, and the latest, the ESRA recommends is discontinue rivaroxaban 72 hours prior to neuraxial block. Sorry. The first or next dose of rivaroxaban should be given only 6 hours after the neuraxial puncture or neuraxial catheter withdrawal. Also, you have to be aware of the risk of postoperative bleeding when you start these drugs. Now, apixaban is another drug, newer oral anticoagulants. There should be at least 26 to 30 hours time interval between the last dose of prophylactic dose of apixaban when you're giving it 2.5 milligram per day and the subsequent neuraxial puncture, catheter manipulation or removal. If a dose of 5 milligram per day is used and when you have a higher serum creatinine level of 1.5 milligram per deciliter, or when the age is higher, 80-year-old, you need to have a time interval of 40 to 75 hours, which should be considered because of the clearance issues. Apixaban should be discontinued 72 hours prior to neuraxial block. This is the newest recommendation by ESRA. And the next dose of apixaban should be administered at least 6 hours after neuraxial puncture or withdrawal of the neuraxial catheter. Edoxaban again 20 to 28 hours. Sorry, let's move. Should be 20 to 28 hours time interval between the last dose. You need to have 2 half-lives. When you use a preventive dose of edoxaban when it's less than 30 milligram per day, and the subsequent neuraxial puncture catheter manipulation should occur only after 20 to 28 hours. When you use a higher dose, there's a creatinine clearance abnormality on when you have a concomitant plated inhibitors, glycoprotein inhibitors, a time interval of 40 to 70 hours should be observed. That is, you need to have 4 to 5 half-life to be crossing. Now, betravaxin is another new drug which has come up. You need 72 hours between the last prophylactic dose and during a neuraxial procedure. Also, when you have a low creatinine clearance and when you have other drugs being used, you need to have 76 to 135 hours, that is 5 half-life should be observed. Now, direct thrombin inhibitors, you have parenteral as well as oral. The one which we commonly come across is dabigatran. Again, dabigatran has to be discontinued 72 hours in patients with creatinine clearance of 80 ml, that's a normal, and 96 hours when it's between 50 to 79, and 120 hours when the creatinine clearance is less than 30, less than 50. And neuraxial catheters can be removed 6 hours prior to the first postoperative dose. The antiplatelet medications, what we routinely see come across is ticlopridine, clopidogrel, and prasugrel. Ticlopridine has to be discontinued for 10 to 14 days. Clopidogrel should be for 5 days, and prasugrel for 7 days. And these are all thienopyridine derivatives. It may be reinstituted 24 hours post-operatively. That's a grade 1A recommendation. Sorry. So if a loading dose is administered, recommendation is a time interval of 6 hours between the catheter removal and administration. And Europe actually, labeling of clopidogrel, prasugrel, and ticagrelor recommends that they all be discontinued 7 days prior to elective surgery. I'll take 5 minutes. Hence, somewhat a longer interval is typically advised in European recommendations. So when you go through that, you'll see that it's 7 days for all these drugs. Now, some of the other antiplatelet medications which have the platelet glycoprotein receptor antagonist, glycoprotein 2B3A receptor antagonist is abciximab, ftipibutide, and tirofiban. And time to normal platelet aggregation following discontinuation therapy ranges from 8 hours for eptifibutide and tirofiban, and for 24 to 48 for abciximab. Now, there are some patients who come with silestazole also. There's a phosphodiesterase 3A inhibitor. The European Society of Anesthesiologists recommends include maintaining the time interval of 2 elimination half-lives, that is 42 hours after the last dose of silestazole prior to neuroaxial blockade, and the next dose administered at least 5 hours after the neuroaxial catheter manipulation or removal is done. And this is a European Journal of Anesthesiology. There's a guidelines by ESRA. This has come in 2022. They have actually in this article, they have shown about 2 categories of nerve blocks for regional anesthesia. That's a deep nerve blocks and neuroaxial blocks, as well as superficial nerve blocks. In superficial nerve blocks, what they have recommended is you can still go ahead with doing neuroaxial blockade with a lower risk when it's a superficial nerve block, because you can actually compress the area where you give the block, and you have to identify that there's no vascular structures in close proximity to neuroaxial bundle. So it's easier to control bleeding. So they have recommended, they have actually not given an absolute contraindication for superficial nerve blocks in patients releasing all these antiplatelets and the other drugs. So deep nerve blocks, again, you need to use with caution. This is just the list of the deep and superficial nerve blocks was there given in the article. Now, one thing which I forgot to mention earlier is the vitamin K antagonist, warfarin, which is commonly used. And as you know, everyone knows that you have to have a 5 days withdrawal of warfarin before the procedure is proposed. And if you need to continue thromboprophylaxis due to some valvular issues or other cases where you can't withdraw it completely, you need to do a bridging therapy with low molecular weight and fractional heparin. So following neuroaxial procedures, the next dose of vitamin K should be administered according to guidelines on postoperative venous thromboembolism prophylaxis or therapeutic anticoagulation. And in the presence of indwelling catheter, neuroaxial catheter, next dose of vitamin K antagonist should be administered only after its withdrawal. In the interim, a low dose of low molecular weight heparin may be used while a neuroaxial catheter remains in place. Those are all 2C recommendations, 1C and 2C recommendations. This is what the European Society of Regional Anesthesiologists have recommended. This is all available on the net. It's almost similar to what we have gone through about the ESRA guidelines. It's given in detail. Aspirin, as you know, there's no need for stopping aspirin 3 to 5 days before surgery like what we had thought of earlier. But still, for intracranial procedures and spinal surgeries, it's still recommended to withhold it for 24 to 48 to 72 hours. That's what we follow these days. Now, there's another article which has come up in regional, it's in British Journal of Anesthesia in 2021. Again, it's a regional anesthesia and patients at risk of bleeding, almost similar recommendations what we have gone through ESRA and ESRA guidelines. This is something what we find in Mysore website when you go through it about each of these drugs, what we use about the oral anticoagulants and antiplatelet drugs, and the guidelines regarding the intervals before and after neuroaxial blocks. This is all available on the net. And there's something which I found in the one of these articles where they have actually given a presentation like this, where they have shown the surgery date. And these are days 1, 2, 3, 4, minus 1, 2, 3, 4, 5, 6, 7 is the days when you have to actually stop. So for vitamin K antagonist, warfarin, they have shown that stopped at 5 days. and consider bridging therapy in specific day from third day onwards. I don't know whether you need to follow this, but it's given in an article over here. And after surgery, you can start for unfractionated heparin on day after 24 hours or low molecular weight heparin. Restart vitamin K antagonist with low bleeding risk and after day 1. And with higher bleeding risk, you start it after 48 hours. And for the newer oral anticoagulants drugs, stop with impaired kidney or liver function. Apixaban is a drug which actually has got a hepatic excretion, so you need to be careful in these liver disease patients. Rest of the drugs which you find is usually more of this, 2/3 of drugs will be eliminated through kidneys. And you have to stop 2 days prior to surgery, and no bridging is required. And restart with low bleeding risk on day 1, and restart with high bleeding risk after 2 days. And for antiplatelets, prasugrel, clopidogrel, and ticagrelor, as I told you earlier, European recommendations, they asked to stop it around 7 days earlier. Here what you see is like 7 days before procedure, you stop the prasugrel. 5 days before that, you stop clopidogrel and ticagrelor 3 days before surgery. And you can restart it after 24 to 48 hours after surgery. It's a small presentation which is, I found it in an article which may or may not come of use for you. Thank you.